everyone, good evening and welcome to this session of ENT. I am your ENT educator, Dr. Vyshnavi. First of all, let me confirm with all of you if you're able to hear me and see me well. If the audio visuals are clear, then we can proceed there with the discussion. Good evening, Dhana. Yes, so I hope all of you are able to see me and listen to me. Okay, so first of all, many congratulations for having cleared the biggest exam of your life, which you were waiting for since quite some time. You've been preparing this for the entire year and with so much of effort. So I'm sure now you're very relaxed, you're feeling better, the stress on your head is gone. So just attend this session with a general free mindset. Don't take a lot of pressure. What you've answered right, what you've answered wrong, whatever's done is done. That's not going to change our answers or our rank. It's going to be there, and obviously I'm sure all of you must have done really well, but I'm just saying that don't take anything this to your heart and just feel sad or anything of that sort. If you've done good. If not, it's also okay, because if you have not done well or if the paper was tough, it is going to be similar situation for everyone. So nobody can exactly predict what rank you will get at this point of time, but yes, tentative rankings you can get. Okay, so is the volume really low or is it fine with everyone? Dr. Rupa says that it's very low. Okay, so with this, I think it should be fine because the volume on my system is good. So I think it is fine. Let's begin our class. Okay, so I am not able to talk really loud because I'm having a URTI and a little bit of infection. So I am talking a little bit in a low tone. Maybe for that reason you're not able to hear really well. But having said that, I'll try my best to increase my volume to explain your things better. Okay, fine. So let me explain, tell you something before we start the session, that this is basically a recall based session where the students have given me the questions. I'm not assuring you that the exam language or the question language is exactly the same and the options are exactly the same. They are more or less similar to what was there in your examination, and the final actual questions, which we will take a cumulative questions from recall from many students, we will take that and upload it on the app. Okay, so let's begin with the first question on ENT. A patient had a negative Rinase on 256 Hz and 512 Hz tuning fork, but a positive Rinase on 1024 Hz tuning fork. What is the airborne gap? Is it 15 to 30 decibels, 30 to 45 decibels, 45 to 60 decibels, or more than 60 decibels? So whatever you think is your answer, please mark that in the chat box or let me know in the chat box. Yes, Aryan, it's basically airborne gap. What we see is a feature of conductive hearing loss. There is no airborne gap in sensory neural hearing loss. So when we are doing a Rinase test, we compare the air conduction with that of bone conduction. And when we say Rinase positive, what is the inference of a Rinase positive patient? It means that the air conduction is greater than bone conduction, which means air conduction is longer and louder than your bone conduction. So air conduction is longer and louder than your bone conduction. This is seen in two situations. The two situations where you see this is either the patient is normal or the patient is having sensory neural hearing loss. So Rinase positive is seen either normal or sensory neural hearing loss. Where do you get Rinase negative? A Rinase negative is seen in conductive hearing loss, where air conduction is lesser than bone conduction. So where do you get this? Air conduction is lesser than bone conduction in conductive hearing loss. So the question is not asking you, is this conductive, is this sensory neural, or is this normal? They're asking you the amount of gap, air-bone gap, that is present. But how are we going to understand the airborne gap? To understand the airborne gap, you will have to know the amount of hearing loss you will have with each tuning fork, like 256, 512 and 1024. Just give me a second. I will upload another page so that we can discuss that. Yes. So whenever you get a tuning fork which has a negative Rinne. So Rinne is negative at what hertz? The Rinne is negative at 256 hertz. But the Rinne is positive at 512 hertz and 1024 hertz. The airborne gap is somewhere between 20 to 30 decibel. Now if Rinne becomes negative at 256 hertz and 512 hertz, meaning if you shift this here, the hearing loss is only going to increase, but it is positive at 1024, which is asked in your question. The answer will be the airborne gap is 30 to 45 decibel. And if the Rinne is negative even at 1024 hertz, then the airborne gap is 45 to 60 decibel. So the question mentioned that the airborne gap, they asked you that the Rinne is negative at 256 and 512, but it is positive at 1024. So what will your answer be? 30 to 45 decibel. Yes. So if you see the options, the correct answer is 30 to 45 decibel. Option B. Okay. So let's go to the next question. A child presented with biphasic stridor, the X-ray image is given below. Which of the following is the diagnosis? Now this is a very typical question which comes in every examination, and we keep insisting to read this question or read this topic every time, and it is something that has occurred recurrently in every exam, be it FMGE, be it NEET, be it INI-CET. Yes, so whenever you hear the word biphasic stridor, first of all, you should know that the lesion is between the vocal cord, your subglottis, and your cervical trachea. Anything in the thorax will cause expiratory stridor. Anything above the vocal cord will cause inspiratory stridor. So anything between the vocal cord and the thoracic trachea would cause a biphasic stridor. Now X-ray is showing you something very typical. What is this typical sign that you see here resembling the steeple of the church? This sign is called as steeple sign. And steeple sign is a definitive hallmark of a condition which we see is croup. What is croup? Croup is laryngotracheobronchitis. We know that laryngotracheobronchitis is a pediatric emergency. Here you will have inflammation of the larynx, trachea and the bronchus. So laryngotracheobronchitis. So there is inflammation of the larynx, the trachea and the bronchus, as a result of which they are going to have narrowing of the airway. And what do we know? Pediatric airway, the narrowest portion is subglottis. So the narrowest portion in pediatric airway is subglottis. So here, because there is narrowing of the subglottis, you're going to get subglottic stenosis, which is marked by your steeple sign. So the correct answer is laryngotracheobronchitis. Now you might ask me, why not subglottic stenosis, ma'am? Because here the X-ray finding that you see is very typical. Steeple sign is something that you see only in croup. In subglottic stenosis, there may be narrowing because of thickening of cricoid cartilage, but a characteristic steeple sign may not be seen. But when you're given an X-ray finding of steeple sign, you have to think about acute laryngotracheobronchitis or croup. In epiglottitis, what do you get in epiglottitis? In epiglottitis, you will get a thumb sign. And in a foreign body obstruction, obviously you can see some foreign body that is obstructing the airway. So the correct answer is laryngotracheobronchitis. I'm sure everyone has answered this absolutely right and are feeling really happy about it. Good. Now identify the marked structure. Is this tubal tonsil? I think the question was asked marking this structure. I am not sure. So they had asked you what is this structure over here. So is this tubal tonsil, is this fossa of Rosenmuller, is this eustachian tubal opening, or is this torus tubarius? Yes, I'm waiting for your answers. Okay, so many of you are telling it's B, fossa of Rosenmuller. I agree with you that this is fossa of Rosenmuller. So in the nasopharynx, if you see this opening just behind the inferior turbinate, this is the opening of eustachian tube. This eustachian tube is covered by a cushion. This cushion is called as torus tubarius. This torus tubarius has a recess behind it, and this recess is called as fossa of Rosenmuller. I'm sure everyone has marked this rightly. Fossa of Rosenmuller is the most common site for origin of nasopharyngeal carcinoma. Okay, so Dhana is saying there was some pale tissue near the tubal opening. So you can have a possibility that they might have given you some tissue over here. If they have shown you some lymphoid tissue, a pinkish, pale, bluish structure, then it can be tubal tonsils as well. So just to avoid the confusion, I have put a video of the nasopharynx so that you will understand the things better, how these things are aligned and what structure was exactly asked. You can see we are going from the nasal cavity into the nasopharynx. This is the opening of eustachian tube. This is your torus tubarius, and behind that we have the fossa of Rosenmuller. You can see here sometimes we can have a lymphoid tissue. That tissue is your tubal tonsil, also called as Gerlach tonsil. Adenoids will be midline structure, but tubal tonsils are your lateral structures. So I hope everybody has marked whatever was exactly asked. If they have given you this recess, it is fossa of Rosenmuller. If they have given you something in front of it with some pale proliferative tissue which is pinkish, then you can mark it as tubal tonsil. Okay? I hope everybody got the answer to this question. Okay. Identify this cancer in a HIV positive patient with a CD4 count of less than 150. Squamous cell carcinoma, basal cell carcinoma, Burkitt's lymphoma, Kaposi sarcoma. Now again, HIV manifestations in ENT is something that you should have a brief idea upon. Although this topic is an overlap between many subjects like say medicine, like surgery in ENT, but we should have a brief idea. So whenever we're talking about HIV manifestations in ENT and we're talking about oral cavity lesion, the most common neoplasm of the oral cavity is your Kaposi sarcoma. So what is the most common neoplasm? We have Kaposi sarcoma, followed by non-Hodgkin's lymphoma, which is a B-cell lymphoma. So Burkitt's is a form of non-Hodgkin's lymphoma. So this is the second most, but here we're talking of most common. Now, why not squamous cell and basal cell carcinomas? See, squamous cell and basal cell carcinomas are not usually found on the palate, but they are found at the angle of your lips or the skin of your lips or on the external surface of your oral cavity. Usually on the palate, they are not present. Second thing is, whenever you see these lesions, the squamous cell carcinoma will appear to you like an ulcer with rolled out edges. And if you see a basal cell carcinoma, which is a very rare occurrence, it will present to you with a rolled in edges. And if you see a Burkitt's lymphoma, it will present as a palatal bulge. What did you see in the prior image? We saw that in the prior image, there was a purple to pink lobular globulated mass. So if you get a purple to pink globular and a lobulated mass, you must think about Kaposi sarcoma, which happens to be the most common neoplasm of your oral cavity. Okay, adenoid was the option. Adenoid cannot be seen in the oral cavity. It will be seen in the nasopharynx, hence excluded, Dr. Mitroid. Thank you for giving me the option. Non-Hodgkin's is second most common. Okay. Okay, let's go to the next question. A child had head injury 1 year ago. Now the patient presented to you with a non-axial proptosis of the left eye. Identify the mass in the given scan. Is this a pseudotumor of the orbit? Is this a ethmoid meningioma? Is this a frontal mucocele? Or this is a juvenile nasopharyngeal angiofibroma? Now let me know what are your options. I mean, what did you mark? Okay, so very good. The most of you have marked this also absolutely right. Ethmoid meningioma was not an option. Okay, so if it's not an option, if frontal meningioma was an option, so fine. Let us take it as a frontal meningioma. Let me correct that option in that case. Okay, so I don't know if it was a frontal mucocele or a ethmoid mucocele, but let us see how to solve this question. Now, this is something that is a little bit, different from the regular questions, although not very difficult to answer, but yes, something that is a little way outside our study. Now, when we are talking about non-axial, so they're giving you non-axial proptosis, meaning it's not an ocular lesion, it is an extraocular lesion that is causing proptosis. So there is nothing in the orbit or an orbital pathology that is causing proptosis. So can we rule out pseudotumor of the orbit straight away because it will cause axial proptosis? Yes. So we rule out pseudotumor. Now we're left with frontal meningioma, mucocele or JNA. Now here we are talking about trauma and proptosis. We are not talking of bleeding, we're not talking of epistaxis, we're not talking of cranial nerve palsy, which is the hallmark of JNA. So let's exclude JNA. Now, frontal meningioma. So, frontal meningioma can cause proptosis, but it is very rarely causing a proptosis of single eye. It is not a very common lesion. And typically, if you see, there will be a dural tail sign that you see in the radiology, which is not being seen over here, which will help us again exclude that this is not a frontal meningioma. Ethmoidal mucocele, as you see, the location in the scan is typical for an ethmoid sinus, which is located near the medial wall of the orbit. We know ethmoid sinuses are located near the medial wall of the orbit. You see a homogeneous density that is pushing the eye outwards. So when you have a lesion outside the orbit and that is causing proptosis and is seen in the ethmoidal region, which is the most common cause of sinusitis in children, and now there is a head history of injury, probability of some foreign body or some infection or some obstruction to the drainage of the ethmoid sinus could have occurred, following which there is an entrapment of mucus in an epithelial lined sac. So if you have mucus in an epithelial lined sac, we call it as mucocele. These mucoceles are known to expand with time, and when they expand, they will push the orbit out. The typical feel that you will get on palpation is called as eggshell cracking feeling. So this is another word that could be given. I'm not sure if it was given or not. Eggshell cracking feeling is the typical palpatory finding. Yes. Uh, can a mucocele present for over 3 years? Yes, it can present to you for 3 years. Mucoceles are not rapidly growing condition, they are slowly growing condition. Post trauma, because of drainage obstruction, which can be happening because of infection, because of trauma, because of a foreign body, anything that's obstructing the drainage can cause retention of mucus. Okay. Oh, so I'm not sure what radiological image was given. If you could share the image on, if you find something similar, can you please share so that we will be able to get to the right answer for this question? Okay. So one more doubt I have is, had they given you the meningocele or meningoencephalocele in your option, because post head injury there is a possibility of defect in the base of skull, and if there is a defect there can be herniation of meninges or meninges with brain tissue, and if there is herniation of meninges or meninges with brain tissue in the ethmoid, that can also cause proptosis. So was this given or not? I'm not sure. So if I get the exact language of the question or the options, then I'll be able to tell. So then I say no. So we will straight remove this out. But it's good to know that if there is a head injury, you should think about meningocele as well. Okay, so then I think the same options were mentioned as given. So I think that we have reached the right answer, which is the frontal or frontoethmoidal mucocele. Okay. Okay, so let's go to the next question. A old patient presented to you with change in voice. He was diagnosed with a cancer and underwent an intervention. Following which surgery, following which surgery is this intervention done? So they're telling to you some intervention is done here for which they have given you a clinical image, and they're telling you when will you do this intervention. Will you do this after partial laryngectomy, after total laryngectomy, after vertical hemilaryngectomy, or horizontal hemilaryngectomy? Again, this is again a very standard question which you can expect in the examination. First of all, tell me, what are you seeing in the image? Okay, so the option was percutaneous tracheostomy. Okay. So if you can see here, the image what they have given you is showing you a stoma or an opening in the region of trachea. So this is a tracheostoma, and through the stoma you can see there is a prosthesis that is fitted, which is near the posterior wall of trachea. So if we take this as the trachea and this as our esophagus, there is a prosthesis between our trachea and the esophagus in patients who have permanent tracheostomy. This is used for production of speech, and what do we call this prosthesis as? We call this as tracheoesophageal prosthesis. So tracheoesophageal prosthesis is something that you're seeing through the stomal opening. So whenever the patient wants to talk, he will occlude the stoma with his finger. Now the air current will go from the trachea through the prosthesis into the esophagus and hit the upper esophageal sphincter or the cricopharyngeal sphincter. And from here you will get acoustic waves which will produce speech. Now, when will we do this tracheoesophageal prosthesis or voice rehabilitation? Voice rehabilitation is done only after total laryngectomy. It is not done after partial laryngectomy because you still have some portion of the larynx to vibrate to produce sound. But when we don't have the larynx only, then you will have to create another vibrator, and that vibrator now is your cricopharyngeal sphincter, and that is why we use this as the vibratory region in patients who have undergone total laryngectomy. So if the option was standard tracheostomy, percutaneous tracheostomy, see in a standard tracheostomy, you will not see any prosthesis like this. You will see through the stoma a tube going in. In a percutaneous and a standard tracheostomy, if you see externally, no major difference will be seen except that the technique is different. In percutaneous tracheostomy, we just make a incision, small incision on the skin, and we go to the trachea with the help of a needle and with the help of a Seldinger technique where we pass guide wire over that serial dilators to open the trachea, and then we push in the tube. Unlike percutaneous, in open tracheostomy, we cut the skin, we retract the muscles, we retract the pretracheal fascia, and we make an opening in the trachea and then insert the tube. So here it's basically a open procedure, whereas percutaneous is a more conservative procedure. But if you see, the external thing will look more or less the same. Okay. So if the question was not similar, please do post it in the chat box. I will follow the questions after the class, and I will try to make a final summary of the questions and post it on the app. Okay, fine. Now let's go to the next question. Which of the following is not an indication for the following device? Pulmonary toileting, upper airway assessment, acute upper airway obstruction, prolonged mechanical ventilation. Okay, so I'm seeing that many of you are giving me inputs on the prior question. I will go through those inputs and I will cumulatively take a consensus as to what majority is telling me, and then we will come up with, for that question, what was the correct language and correct options. Maybe in the app we will put up the corrected version. Okay, so here, which of the following is not an indication? Absolutely right. Many of you have answered it absolutely right, which is option B. So this is a tracheostomy tube. So if you see that this is a standard tracheostomy tube, this is a Portex type of tracheostomy tube. Now, why do we do a tracheostomy? Whenever we want to bypass the upper airway. So, whenever we're bypassing the upper airway, we are having either an upper airway obstruction, and to prevent that to relieve the upper airway obstruction, we are doing a tracheostomy so that the patient can breathe. So, this is the right answer, meaning that this is an indication. Prolonged ventilation. Yes, in prolonged ventilation, you need a cuffed tube. So if you see there is a cuffed tube, this is going to prevent aspiration, going to give a good volume of air into the lung and help in mechanical ventilation in a better way. So this is definitely going to help you. Now your question is, why not endotracheal tube? Why only tracheostomy tube? See, endotracheal tube we can use for maximum of 7 to 10 days in a safe way. Of course, we can use it for beyond also, but beyond 7 to 10 days, if you use, there is a possibility of complications. What complications? It can cause most commonly a subglottic stenosis. It can cause pneumonia because of poor pulmonary toileting. So, of course, after 7 to 10 days, if there is a patient who is definitely requiring a prolonged ventilation, we change from ET tube to a TT tube, tracheostomy tube. So, 7 to 10 days, you're going to wait and you're going to see if the patient is on ventilation and requiring ventilation beyond 7 to 10 days, you're not going to put an endotracheal tube, you're going to change it to a tracheostomy tube. Now, pulmonary toileting is also an indication, because if you're putting an endotracheal tube, it is from the mouth going to the trachea. But a tracheostomy tube is going from the second tracheal ring to the and is in the trachea. So where will you have a lesser dead space? If you see from the mouth, this much is the amount of dead space that you have. So from here to go into the lungs to clean the secretions from the lungs is going to be lesser effective versus the one that you're going to do through a tracheostomy tube. So clearing lung secretions will be more effective and better when you do a tracheostomy versus endotracheal intubation. So here again, this is also an indication. Upper airway assessment is not an indication. Upper airway assessment you can do even without tracheostomy. So I'll just show you what does upper airway assessment mean. So we can see that we are passing a fiber optic scope from the nose and we are going into the nasopharynx. You can see the tubal opening, the torus tubarius behind, and we are now in the nasopharynx. From the nasopharynx, if we go down, one second. Yes, from the nasopharynx, if we go down, we will reach the oropharynx. And from the oropharynx, we will reach the hypopharynx or the larynx. Yes, don't worry, even if you have made a mistake, that's fine. Absolutely okay, but just an understanding for your betterment, I'm trying to tell you all of this at the moment. So you see our scope is in the nasopharynx, and if we see down, we will be going into the oropharynx. And down there you see is your oropharynx. And if we go further down from there, where are we going to reach? The hypopharynx and the laryngopharynx. So we assess the airway at the level of nasopharynx, where we are seeing the closure of the passivant ridge. We are seeing that it is nice and closing the nasopharynx from oropharynx at the time of swallowing. Once we have confirmed the passivant ridge is working well, then we go down into the oropharynx. Okay, so in a minute or so, you will see that I am going down into the oropharynx. And from the oropharynx, we will go down into the hypopharynx or the laryngopharynx. Yes, so this is all the fibers of the passivant ridge which we usually test for nasal regurgitation if it is present or absent. So this is an unedited video. I didn't have time to edit this because we had the session immediately following the exam today. So we are just going down and you can see that we are in the oropharynx, and you can see the larynx with the epiglottis down, the vocal cords, and behind the larynx will you have the hypopharynx. So we can see the oropharynx, then going down will be your larynx, and going down will be your hypopharynx. So this is how we assess the upper airway, and that does not require a tracheostomy. Okay, a patient has enlarged tonsil and is unable to swallow. Patient is also complaining of ear pain. Likely source of ear pain is auricular branch of the vagus nerve, tympanic branch of the glossopharyngeal nerve, greater auricular nerve, or the mandibular nerve. Again, this is a standard question that we read for the chapter referred otalgia. So whenever we talk of referred otalgia, there are various nerves that are involved in the causation of referred otalgia. Yes, Abhishek, I'm coming to that question in a while. Okay. So when we're talking of referred otalgia following tonsillitis, so they're telling to you that there is an enlarged tonsil and the patient is unable to swallow and is complaining of ear pain. So we are basically talking about tonsillitis. And whenever we have tonsillitis, the pain can radiate to the ear via the glossopharyngeal nerve. The tonsil, the oropharynx, is supplied by the glossopharyngeal nerve. The glossopharyngeal nerve in the middle ear gives rise to its tympanic branch. So, tympanic branch of the glossopharyngeal nerve, we call it as Jacobson's nerve. So, via the Jacobson's nerve, it can cause ear pain, which we call it as referred otalgia. So following tonsillitis, it is tympanic branch of glossopharyngeal nerve. Now what about auricular branch of vagus nerve? So whenever there is a lesion of the laryngopharynx, which is nothing but your hypopharynx or your larynx, you will have pain referred via the auricular branch of the vagus nerve. Mandibular nerve supplies your face, your oral cavity. So any lesions from here will be radiating via the auriculotemporal nerve. So fifth nerve, ninth nerve, 10th nerve are responsible for causing referred otalgia. Okay. A student is yawning in an afternoon class and got stuck in an open mouth. Which of the following muscle is responsible? Is it masseter? Is it lateral pterygoid? Is it medial pterygoid or temporalis? So this is something that happens quite frequently. We see as an emergency where patients come to you and they will tell you that we were yawning and my mouth got stuck and mouth is open, I'm unable to close the mouth. What would be your answer for this particular reason? So for that you need to know the function of the muscles which are responsible for mastication. So if you see masseter, temporalis, medial pterygoid, all of them are responsible for closing the jaw. But if you see the lateral pterygoid, it is responsible for opening the jaw. So which is the only muscle that helps in opening the jaw? It is your lateral pterygoid muscle. So when the mouth is opened while yawning, there could be a possibility of spasm of the lateral pterygoid pulling the condyle of the mandible from the articular surface of the tympanic bone. So there can be a possibility of TMJ dislocation. And when there is a TMJ dislocation following excessive wide opening of the mouth where the condyle gets disrupted and gets locked, we call it as lockjaw. And this happens due to spasm of which muscle? It happens due to spasm of lateral pterygoid muscle. So this is not the answer. It is the lateral pterygoid muscle. So I hope all of you got it right. Okay. Next question, the last question. A patient presented with progressive swelling from last 2 years. On examination, there was a dense, mobile and a nodular mass shown in the image. What is the most likely diagnosis? Parotid gland tumor, jaw tumor, dermoidosis, sebaceous. I think this is a fairly easy question. Even if you don't know, first you need to know what is the area where this lesion is present. So this area where the lesion is present is nothing but the area of your parotid gland, and whenever you have a lesion at the angle of mandible, we are going to define it into two types, a solid mass or a cystic mass. Now they have given to you very clearly that the mass is dense, mobile and nodular. So we are going to put out the cystic masses from our options because they have told you it is dense, it is nodular. So dermoid and sebaceous are going to be out of question. Now, if there is a tumor that is a jaw tumor versus a parotid gland tumor, both of them can present to you as a swelling at the angle of mandible. But if we see the most common tumor that happens in this region is going to be a parotid gland tumor, commonly a pleomorphic adenoma. So we are going to answer this as parotid gland tumor. I don't know the exact image, but whether it was at the angle of mandible, a little in front or little in behind, it's still going to be a parotid gland tumor. Okay. Okay, Dhana, and okay, others, whoever have mentioned that it is front also. Yes, this entire area is the region of parotid. So even if you have a swelling on this side, it's still going to be your parotid gland tumor. Okay. I'm not sure what image was given because I didn't see the paper, right? So based upon recall, whatever is the best possible image that I could find and I could relate, I have put in. But having taken inputs from all of you, I'm going to revise these questions, one or two which you said that these were not the exact options. I'm going to reframe them so that the next people who are going to appear for the next examination will get a better idea of what was the quality of questions, the topics that they came from, and they will be benefited from that. I would like to thank all my dear students who have given me these questions and all of you for logging in during the class and helping me with these options and uh, taking your time out to listen to this recall. And finally, don't go heads on understanding or recalling how many I did right, how many I did wrong. Just relax. The results will be out just in a few days and just leave it to Lord and enjoy. These are the few days which you will have to enjoy because once the results are out, you'll get again busy with something or the other. So now just relax. You put in your effort. You did whatever best you can. Now you can't go back and do anything about it. So just have fun. कुछ भी हो जाए हमें करना है मस्ती and just do that and I'm sure you're going to feel much better than what you're feeling now. Just relax, sleep well, and if you haven't subscribed to our channel, do like, share, and subscribe. Okay? So take care, everyone. I'll see you again, and bye bye.